Good morning, or good afternoon, depending on where you are. This is Dr. David Nace from Innovator. Welcome to this webinar. We are just going to give this about 30 seconds to allow everybody to get on the webinar, and we'll get started in just one moment. Please bear with us. Great, it looks like things are settling out. So for those of you who just joined us, this is David Nace, Chief Medical Officer here from Innovator, and welcome to this webinar. Leveraging value-based models to improve quality, reduce costs, and transform the care experience. So with no further ado, let's get started, and let me welcome our panelists. First, I'm very pleased to welcome Brandon Burkett. He's the Assistant Vice President of Value-Based Care and Population Health at Orlando Health in Florida. Brandon, great to have you with us.
Thanks, David. Appreciate you. I'm glad to be here.
Awesome. We're looking forward to hearing about your experiences in Florida. And also my good friend and colleague, Dr. Paul Grundy. He is the convener of our Care is One network and the Chief Transformation Officer here. But many of you know him as the godfather of the patient-centered medical home movement. Paul, welcome.
Thank you. It's a pleasure to be with you, and Brandon with you.
As always, of course. So with that, let's get into the topic at hand. So, we've just got through this pandemic, or at least it feels like we're getting through toward the end. I think we're getting close to hitting the 70% mark nationally for at least one vaccination. And the cost of healthcare is still high. Paul, let's start off with you. You've been dealing with healthcare from a national vantage point for quite some time. What's going on in healthcare?
I think a lot of the things that Brandon and you and I and others listening, what we're expecting to happen in the next 5 years or decade, got sped up into a few weeks with the onset of the pandemic. There was a lot of clarity about social determinants of health. And with the current administration, I think we're seeing a speed up of a sort of move to value and away from an episode of care and to proactively managing a population with data. And a large part of that is there's only really one way to herd a cat, and that's to move the food. And I think the food is being moved into a position where Brandon is going to explain, how they're responding to that movement of payment.
Brandon, 70% of Americans say healthcare is in a state of crisis. What's going on there?
Yeah, I would echo some of the comments of Dr. Grundy there. I think COVID has interestingly catalyzed a lot more of this fervor towards value-based care, particularly in our market with a lot of this large self-insured employers striving for some financial solvency at this point and looking for value-based options to manage their most expensive benefit, which is their medical plans. So, healthcare has never been built and structured in a way from a financial perspective where the arrangements drive value inherently. So these new models that are placing greater risk on providers to deliver care and is frankly what the employers and the payers are seeking is what's helping us move in that direction. Originally a little bit more slowly, but I think as Dr. Grundy mentioned, been certainly accelerated by some of the recent happenings and definitely some legislative and regulatory changes that are moving us that direction more quickly as well.
Well, we've really experienced this issue of risk as we've been into the pandemic, and it's always been an issue around risk when we talk about value-based care, population health, patient-centered medical home. Brandon, how well do your providers really fully understand the concept of risk? Is it pretty uniform or is it highly variable? Lots of room to improve.
It's variable. We're in our 8th or 9th year right now of our value-based care journey at Orlando Health. So I would say we've matured a little bit beyond kind of some of the getting our legs under us stage. I'd say it's highly variable though if you look across the country, market to market, of what the evolution of value-based models are in the individual markets. But because of some of those recent landscape and industry type changes that we're experiencing, it's probably going to be accelerated more globally than what we had seen previously. A lot of it's been driven by the appetite of the payers in those markets And what we've been doing as a network over the last several years is trying to slowly, from a glide path perspective, move our providers in a comfortable space to take on this risk and to manage the populations more holistically.
I like that term holistically. So, we often talk about clinical risk, but we're also talking about non-clinical risk. Dr. Grundy, how do you view non-clinical risk?
Yeah, so an interesting story. One of our large clients, we began to see an uptick in hospitalization for hypoglycemic events. And when we began to look at data, it was in a few zip codes and it was the end of the pay period. And what we saw clinically was a bunch of docs adjusting the insulin and the medication. And what was happening to the patients was they were running out of food. And I think that's a great example of an integration of the social determinants of health and clinical integration. When a body in a bed was a profit to a system, and the food was there for the cat, there's a whole different view than when a person in a bed is a loss. And, when that begins to happen, all of a sudden, these other issues begin to be really important to the community. We saw that earlier in Maryland when they capped payment. All of a sudden, they were beginning to work with local community organizations to address some of these issues.
Well, this is really enlightening. Even when you look at clinical risk, not just non-clinical risk, we've always talked about how technology and analytics can really help to identify that risk. Brandon, how do we think about dividing up risk when we look at a population and think about population health?
Yeah, so this slide, kind of makes me think of the traditional pyramid model where you're looking at the top end, the highest risk population, and then you've got a rising risk cohort that's somewhere in the middle. And then you typically have your more indifferent or very healthy population toward the bottom. The way we think about it from a pop health perspective is we certainly have to tackle the top of the mountain. Those are the highest cost patients, but oftentimes they're some of the most challenging to manage. And with limited resources, we have to think about how we deploy our resources, our technology to tackle those folks, and also understand that they're going to probably have lower level rates of engagement and possibly adherence as well with any of the protocols that we work with them on. So it's equally important to go after those rising risk patients. That's where a lot of the advanced analytics come in to move away just from purely reactive care, right? These patients that are on the top of the mountain because they have multi-comorbid conditions, they have extreme uses of ER and inpatient stays and what have you. But the rising risk is probably the more difficult population to tackle until you get data. And that requires data from a variety of different sources beyond just the clinical points, as you noted, Dr. Nace. We really have to begin to look at things that are commonly captured in community health needs assessments, like access to food and water and transportation services and violence and education. Lots of things that are not traditionally considered in the kind of grand scope of how we deliver medicine. But as we begin to take on these value-based arrangements, it's increasingly important for us to consider all of those factors. And this rising risk population represents one that we probably have some of the greatest opportunity to inflect care on and drive down the cost of care in a proactive way, as opposed to being totally reactive to medicine. That's the kind of general precept of population health, is focusing on a broader cohort of population and being able to do things that are preventative in nature rather than purely reactive and curative.
I think of this as every patient needs a plan, right? This whole model of care is, it could be a simple plan and it can be automated. My cat gets notification it needs immunizations. The concept of aspirin, blood pressure, cholesterol, the ABCs, smoking. If you just began to focus on that, studies have shown you see a 30% reduction in the need for hospitalization for cardiac events. But if that's going to be effective, Brandon, it's going to have to be automated, right? There's going to have to be, you're going to have to be able to engage your patient the way Amazon shops you.
That's right. Yeah, that bottom part of the pyramid, that 60–80% here on the slide, those are the populations that are probably most eligible for those more automated solutions, right? And it allows your resources to be more equitably distributed toward the top end, which requires a lot more human intervention and hands-on care. It allows you to be more efficient as an organization while still managing the entire population that you're at risk for.
That makes a lot of sense.
But across that spectrum, they all need a plan. It just could be a simple plan and automated. Absolutely.
So Brandon, an organization like Orlando Health, you've got lots of different types of contracts. And like most health systems, you're largely in a fee-for-service environment and moving more and more into sort of these lightweight, value-based care contracts, and then maybe heavier degree of risk. So I think it's really important to understand the risk of each population. How do you think about that? How do you go about it?
Yeah, this has been quite a learning experience for us. So, rewind the clock 8 years, 0% of our dollars as a system from a revenue standpoint were coming in through value-based arrangements. Today, it's about 24%. So we've evolved quite a bit, in a very short period of time. And what we've learned during that journey is that the clinical care management, the doctoring, the care coordination, everything that we do to manage the cost aspect is wildly important, not just from a cost standpoint, but really from a quality standpoint. But regardless of all those efforts, if you're not doing well on the risk coding element, then you're going to be starting underwater all the time, because that's what sets your benchmark, that's your revenue. So when you think about it from that standpoint, you have to tackle both sides of the coin here. You have to hit the expense side, which you do through all of those care coordination and care management efforts, care redesign. But to do the revenue side of the equation, risk coding is the principal lever and driver that you have there. And I really think about it in 3 ways. There's a financial aspect of it, there's an operational aspect of it, and there's a quality aspect to it. When you do risk coding and you do risk coding well, there's obviously the financial consequence of getting paid potentially more on the fee for service, the per click aspect of it. And the shared savings aspect is the more downstream element to that, because it's increasing your benchmarks that you're measured against. From an operational perspective, it actually ties back into quality, because the risk coding that you do drives the risk stratification of the patients that go into the care protocols that you're managing. And finally, from a quality perspective, all of our quality measures that we're judged against are typically risk adjusted. So if you're not capturing the acuity of the patients that you're managing, whether it's something simple like a geometric mean length of stay, or something more complicated like a 30-day mortality rate, the acuity rates that you're able to reflect through your risk coding and risk adjustment are wildly important. So for us, it's multi-pronged, and it goes beyond just the financial and economic value of doing effective risk coding.
You bring up a great topic. I mean, even in a fee-for-service world, as you begin to move towards quality, improving, and you begin to learn how to manage a population, we see an ROI of 3.9 to 1 by identifying those issues that need to be addressed, your wellness exams, your immunizations, your screening exams, and making sure that the patients are notified and bring them in to do that. And so you're really preparing yourself, to manage risk more effectively. At the same time, you're in a fee-for-service world. It's sort of a win-win.
So this sounds like it's much more complicated than many people thought about, in terms of understanding risk. And it sounds like also it's an ongoing process, right, in order to really identify risk. Then the question becomes, what do you do with that? So let's take this common problem, which is a big one, around someone leaving the hospital and then trying to prevent them from having a readmission. Paul, let's start with you. How effective have we been at understanding who is at risk of a readmission and then preventing that readmission from occurring?
One of the places that have begun to address that pretty effectively is what Brandon and his team are doing in Orlando. And that's really focusing on that follow-up immediately after the hospitalization. So, Brandon can tell us about it, but they use their emergency technician service, to do medication reconciliation, to make sure people aren't tripping over a rug, to sort of do a home visit, and then really making sure that the patients know when they should be followed up with, right? But boy, would love to hear the results of that, Brandon.
Yeah, so one of the major interventions that we've spoken about previously is our community paramedicine program. We have a variety of different ways that we're trying to commoditize care and get into patients' homes beyond the kind of MECA model of patients having to come to us, right, becoming more patient-centric. And we've done house calls and home health agencies, but one of the most impactful, kind of going back to the theme of beyond the realm of clinical care delivery, has actually been working with our community paramedics, which don't really deliver care, but they are doing a lot of the socio-determinants of health barrier removals for us. And so with that group, they're going to patients' homes, they're assessing, trip hazards and looking at pantries and helping with med reconciliation, things like that that are very, very important to preventing readmissions. And just as kind of a quick kind of synopsis of one of the studies that we did through a grant program with that group, we took a group of 30 patients that had 90 readmissions in 1 year to one of our hospitals, and we deployed community paramedics to them every single week for a year. And at the end of that year, that same cohort of 30 patients had 0 readmissions the following full calendar year. So a very, very dramatic result on a very small population of patients that were driving a lot of excess and unnecessary care. The cost savings were immense, but the quality benefits and the patient satisfaction ranks were off the charts.
That's so impressive. And I think about how in the traditional care management transitions of care model with telephones, this is what's illustrated here in this slide, is because of resource constraints, people have tried to focus their care management on that 20%, but then they often call them or try to contact them. They can't reach them. They have the wrong number. They don't have an up-to-date system. We'll get to the importance of data. And then people answer the phone. Maybe they do, maybe they don't. Maybe they want to comply. Who is this person calling me? It's not my doctor. It's not connected, right? From the hospital experience to primary care, who the people that they trust. It sounds like doing these innovative programs, Brandon, like putting people into the home and then connecting with other resources, seems to be very effective.
It is, and with all due respect to two physicians on the call, doctoring is very important to what we do, but the vast majority of what we do to prevent adverse outcomes for patients oftentimes uses a much lower level of resource. And so we were able to do that in a very cost-effective way with our community paramedics and with other resources that are practicing at the top of their license, but are more of a commoditized resource that we can use to meet the patients where they're at.
I mean, it really brings home that healthcare is a team sport now, right? And it's just so complicated that, if you use your support personnel effectively, boy, it just takes the burden off of the clinician, but it makes a difference in patients' lives.
There's a lot of tools that, and I'm using this slide as an example of the National Transitions of Care Coalition, have really, put forth to say, well, how do we think about this issue of really transitions of care? Preventing readmissions is a classic example of that. Thinking about, medication management. How many people go home and don't know exactly what their new medication regimen is? How do you think about tracking the information of what was in the care plan on leaving so that all the members of the team, including the non-clinical members, know that? How do you think about who's responsible for transition planning? How do you actually make sure you have a follow-up care plan that actually works, that you have the right people engaged? How do you get the family engaged, right? The people important to that person's lives. Traditionally, they've been sort of kept out of the picture. There's a lot of different levers here to pull, Brandon. How do you think about which ones are important for which patients?
Well, I think one of our learning lessons with our system-wide readmission focus that we've been deployed on for the last couple of years now is that there are no silver bullets when it comes to a lot of these things. So you really have to kind of focus on every single one of them. It's probably not the answer everyone wants to hear. They want the low-hanging fruit, but every one of these is equally important. And I was somewhat relieved, actually, when you pulled the slide up here, David. We're doing something in every one of those 7 domains. Now, that's not to say we can't do something better, but for medication management, as an example, we in the last couple of years, we've deployed a program, our Meds to Beds program, that every single patient that's discharged from an Orlando Health Hospital is going home with a 30-day supply of medications in hand. There's no considerations around the formulary or the insurance contract, and there's a lot of times that we're having to write some of those off. But for us, it's a matter of good continuity of care and making sure patients have what they need to be successful during that transition. Other pieces of the puzzle here, as I said, it takes a village. So we don't rely on every single Orlando Health resource to solve every problem. You have to rely on other community partners, whether that's home health agencies, skilled nursing facilities, other community resources from a socio-determinant health barrier mitigation front. And one of the big things that we've done as a win to engage patients and families, but also as part of the discharge planning process, we have a team that we call REACH, which actually works, they're all social workers, and they work to solve a lot of these problems before the patients leave our facilities, but they're a regular touch point after the discharge process. So a lot of these can be tackled with common teams and common resources, but I think it would be a little bit folly to believe that, everyone can, one person can do everything themselves. And so I would encourage folks that are going down this journey in any aspect of population health, not just readmissions reductions, that you really need to find out who your community partners are and leverage those resources to drive, transitions of care management, chronic disease management, what have you.
Well, we're interested in learning a little bit more about, specific programs you put in place at Orlando. But for now, let's take a break here and check in with our audience. I'd like to see what they're doing around implementing their care management strategy. So for the audience, two things. First, as an ongoing issue, please put any questions you have during this webinar into the chat box. But for now, let's go ahead and take this poll. What are the ways in which your organization is implementing a care management strategy? And so you can see the choices here. Paul, while we're having people check in on this, Paul, what do you see across the country? I know you travel around and you've been doing this for 25 years, taking a look at what different physician groups and practices are doing. Does there seem to be a lot of variability? Is there a pretty uniform way? What are people struggling with? How do you see the national landscape around implementing a care management strategy?
I sort of look at it through three legs of the stool, and that's the cultural shift, the payment change, and the technology. And I'm really excited that for the first time, I think we're really going to have the data available at the point of care to proactively manage the population. And the breakthroughs that are happening in that, particularly when we've made huge advances in AI checking on itself and being able to get data, right down to the docs level. And I see uptick in that increasingly and making it easier. In fact, saving 2 or 3 minutes per patient from the docs to have the ability to really address your patients in the way that Amazon would shop you, or Google Map would drive you, is I think beginning to make some real breakthroughs.
Yeah, I think we have such a great experience, particularly during the pandemic, ordering things from Amazon. It's pretty frictionless and easy, and healthcare seems to be so complicated. And I think a care management strategy in the complicated, more multifaceted way that Brandon was describing can really help in that regard. Let's go ahead and pull the poll results up and see what people checked in with. Give it just 1 minute. Oh, this is interesting. Brandon, what do you think about these results?
Well, I'm delighted to actually see how many organizations are using data analytics in a concerted way to drive care management. I was listening to Dr. Grundy speak just now, and I think he used 3 different legs of the stool, but the same general concepts that we use, which are people, process, and technology. And the immediate thing that came to my mind is data drives all of those. So none of these things can really be done without that, that yellow bar you see here on your screen, the automated work list, the stratification of patients, all of that requires the data analytics. So that's actually heartening to see. The rest of it is really, applications and algorithms and things that you build on top of the data. So that's actually a very positive thing that we're seeing here.
Fascinating. Well, let's get into what you're doing in Orlando and see if we can take some learnings there for everybody on this talk. Tell us a little bit about Orlando Health.
Sure. So just a quick background for the organization. We're a 15 hospital system. We're essentially based in Central Florida. We've recently expanded in the Tampa, St. Petersburg market over on the Western coast within the last year. We run about 12 different ACO-like operations with different payers, commercial and government funded folks. All told, about 270,000, 275,000 lives that are under management today. And those are relationships, about $1.5 billion in total expenditures. We also have one of the larger community clinically integrated networks in the region, maybe even in the Southeast United States. About 5,300 providers today, which about 1,000 of those are employed Orlando Health badge wearing folks. The rest are community providers. So when you talk about a data complexity situation, having to aggregate a variety of different EMRs and claims data systems, we're certainly familiar with that and have done a lot of work with the Innovator team to pull all that together. And that will speak a little bit more to some slides we talk about a little bit later on about readmissions reductions and how important that is.
Big health system, lots of complexity, lots of different data sources. That seems to capture it.
Yes.
Move on to this next slide. So you've got a lot of different departments, and as I mentioned, there's all different types of contracts.
Yeah, so within our ranks of population health and value-based care, we kind of describe what we do as the ABCs of value-based care. And a lot of these look like buzzwords to people that are just reading Modern Healthcare or ACHU magazines, but A is the ACOs, B is the bundle programs. C, I mentioned our clinically integrated network. We refer to ours as the Orlando Health Network. We also do direct-to-employer relationships, notably the largest in the country with Disney. We're managing about 25,000 of their cast members and dependents. We also manage our own employee health plan, our Orlando Health Team Member Health Plan. And then finally, we do a variety of different focused system-wide objectives, ranging from clinical transformation initiatives like readmission reductions to patient engagement outreach strategies on behalf of our system from the perspective of annual wellness visits or care gap closures, and then also all things technology and how we interface with patients outside the walls of our hospital.
Yeah,
You know, Pam Hamel is the CMO for Disney, is a friend of mine. I've known and worked with her for years. And she really stressed when I talked to her a few years ago that you sort of modeled the direct-to-employee program after your own employee health program. You were able to demonstrate with your own employees a savings, I think, of about 11% reduction in overall cost. And I think that really resonates when you bring that out to the employers in your community. You know, as an employer, we've really managed our own population. And by the way, you know, they're at risk for you, right? So you know, and if you demonstrate that your own population at risk, you know, it's anyway. Pam was impressed and loves the support you give her.
Thanks for sharing that. We love working with Dr. Heimel and the team there. You know, something that you said, Dr. Grundy, resonates with me, and it actually goes back to a comment you made about Amazon a little bit earlier. Maybe Dr. Nace, you made the comment about Amazon, is that a lot of folks don't follow the value proposition necessarily directly. A lot of times people view volume and value as competing you know, agendas, but in reality, if you follow the Amazon model, what they've delivered is a consistent product at an affordable cost, high quality, great experience. That's definitionally value. It's the same things that we're looking for as patients from a healthcare system. And what has Amazon done? Well, because they've delivered a high value platform, they've driven a lot of commerce and users to their platform. So they've actually created volume because of value. I would say it's the same type of paradigm that we're seeing from a value-based perspective in our local market, right? Disney was the first and probably you know, largest name in our market to really kind of push this from an employer standpoint. But there's a variety of others, and partnered with different healthcare coalitions and employer groups that are now kind of really demanding these types of models become more pervasive, if not the kind of table stakes to participate with them.
You know, I like this A, B, C, D. This is a great way for people to think about all of these different types of arrangements and contracts. And you know, I really like what you said about you know, comparing Disney with the support you do for Disney. Great product, great experience. You know, I've had two colleagues, and I would imagine every single member on this webinar has had this experience with friends and family. Two friends that I've talked to just in the past 2 days supporting loved ones, and both of them unsolicited said their experience is horrible. They have disconnects, they're getting misinformation, there's a lot of friction for them. This is something we have to tackle in healthcare, isn't it?
Absolutely.
So let's go to this specific issue about readmission. So, you know, you have somebody in the hospital, they're leaving. We talked about the complexity in doing this. Walk us through how you think about that at Orlando.
Yeah, so you know, when we began this effort, what we found was we had a lot of people that were running really hard in Orlando Health, but all running in different directions. So how did we get everyone to run in a common direction towards the common goal? And it actually is as simplistic as it sounds. It began with a common vernacular, right? How we were defining what we were trying to achieve. And I won't read the slide to you, but this is actually a Forbes magazine framework for how you define goals, strategies, objectives, and tactics, and what's the difference between those. the long and short of it was we identify with our readmissions population, there are some common things that we should be doing across all patients every single time. We call those breadth strategies. They're touching everybody. They're an inch deep, mile wide type approach to things. Whereas depth strategies are more targeted, specific interventions that you're diving really deep into issues with patients on a patient by patient basis. So that was kind of the beginning for us, was to set a common, vocabulary that everyone was using. And then before we even jumped into data or jumped into designing strategies and the objectives that would follow them, we really wanted to do a literature review and figure out what's the best practice, so then we can frame our data measurement and frame our practices and our people and processing technology around those things. So if you would advance a slide here, Dr. Nace, the first thing we did is we looked at the most common acute care best practices. And so this was pulled from a variety of different resources. You can see some of the sources there on the bottom: advisory board, JAMA, other medical literature resources that we pull from. But the common tenets that we picked up on from every one of them were getting follow-up visits timely after discharge, having good medication management, a strong post-acute strategy, the ability to follow patients wherever they're at after they leave the hospital, and then optimizing your actual clinical delivery system within the EMR. So every one of these articles that we touched on kind of looked at these key tenets. And so we wanted to make sure that we had these elements built in. And then the next slide speaks to more of what we need to do after the patients leave the walls of our hospital. How do we stay sticky to these patients? How are we staying tethered to them? And there's a lot of things that we were maybe doing, but only doing partially well or not doing holistically for all of our patients in this area. So in some cases, we were taking information on social determinants of health, others we weren't. Sometimes we were educating, sometimes we weren't doing it as consistently, or we were using different educational materials. So a lot of our kind of initial essay of everything that we were doing began with figuring out the who of doing things, what we need to do, and then it began to evolve into this is how we need to do things and how we need to do them differently. And I would use, a line from Peter Drucker here: if you can't measure it, you can't manage it. So that was where the data became, of the utmost importance for us.
So when you talk about this, what's very interesting here, because you've broken down, like, what do you do in the hospital experience? How do you think about the continuum of care afterwards? How do you use data, information, and processes? How do you achieve the uniformity across your folks in doing these processes? And then also, how do you think about that in terms of the A, B, C, D, E, F, right? The different types of contracts you have.
So it all comes back to data, right? So you have to have ways of being able to measure things to create uniformity and create a standard of care. And that was where our strategy setting, the breadth and depth levels, which I know we'll touch on here in a moment, we built objectives specific to each one of those to make sure we're holding ourselves accountable, and measurement systems that we have within our system to track that. And I would say it's important that when we think of designing any of these programs, we're tracking both process elements as well as outcome elements. And so by that, I mean, we're tracking the what we're doing, but then also what the result is, and trying to tie the two together to understand the efficacy of things. So that's really how you create some uniformity and also get buy-in and credibility from those folks that are actually the boots on the ground operators doing the work. Once they have trust in the data and see the results that they're able to deliver, it makes it much more digestible and more widespread within those ranks.
Awesome. Well, let's get into this depth and breadth. I really like that breakdown. I think it will help the audience think about these categories. So breadth.
Sure. Yeah, so these are the three strategies. We had probably about a dozen we had to cull down to the top three that we really wanted to focus on. But broadly, reducing readmissions is going to be largely driven by good transitions work, right? How you keep patients from bouncing back to the hospital by staying connected to them and making sure that there's not complications. And so if I had to kind of put a weight on each one of these, I'd probably say 60, 30, 10 from left to right. Getting patients in to see their primary care or specialist after their discharge in a timely period is of the utmost importance. 55% of all of our patients readmit within the first 7 days, which suggests it's not a clinical issue, it's a transitions issue. And so we needed to figure out ways that we were going to do that. And we were targeting the populations in this first objective that had the highest rates of readmission, perhaps some of the most complicated. We have other objectives that underlie each one of those, but these are just KPIs that we're using to track ourselves. And then the medication management, also very, very important. Not all patients have to have different medicines when they go home, so it doesn't touch every single patient. Some of them already have different medicines that they're in place, or they're going to skilled facilities or independent living facilities or ALFs, where that's administered through contracted pharmacies. But by and large, there were a lot of patients that were readmitting because they didn't understand their medications, didn't have access to medications, or couldn't afford medications. So we took that off the table as a concern for us by implementing that 30-day supply in hand policy that I mentioned earlier. And we're having pharmacists get to bedside with all these patients to help with the education as well. And then finally, the post-acute network, that's not all our patients go to SNFs, not all our patients go to IRFs or LTACs, but making sure that you have a highly aligned, high-value network, which we've done through a data standpoint of being able to determine who produces the best results, being able to drive patients into that network. And of course, patient choice is always going to trump, so you can't get 100% within your network, but to the degree that if a patient needs to go to a skilled nursing facility or an LTAC or an IRF, you're steering them to those that have the best value and best outcomes for their own clinical benefit, but also accrues to your organization from a value-based perspective.
And I see these little bars, operational owners. How do you think about that within the organization and implementing this?
So from all these different strategies, we assigned two different operational owners for each one of them. We suppressed their names for anonymity's sake here, but each one of these corporate strategies has owners that are responsible for moving the needle forward. These are executives or director level folks within our organization that are to serve as champions to help remove barriers and help move the operational pieces forward. And they're truly the ones that are accountable for these individual KPIs. If we were to rely on a broad task force or steering committee to look at 10, 12, 15 different measures, it becomes a little bit of eyes glaze over and no one can really manage these things. But when you create accountability at a individual leader level and they have just a couple of metrics they're trying to track, it helps move the needle much more and create a broader sense of ownership for the individual measures that they are inflecting.
So I was impressed when I talked to one of the folks that's an operational owner and, looked at me and said, I have a target on my back. I need all the help I can get to get that target solved. And, very seriously, I think it's really impressive that you did that, right? I mean, you just identified an owner and somebody with the target.
So as you think about the breadth strategies that you kind of look across the board, that makes a lot of sense. How do you think about these depth strategies where you're targeting a specific population?
Yeah, so this was probably the most data-driven piece of all of our work that we did with readmissions. As I'm sure most of the listeners know, the Pareto rule, 20% drives 80%, right? And what we found was that we had 350 patients rather that were driving 20% of our overall system-wide readmissions. That's about 2,000 readmissions a year from just 350 patients. So these patients were, by and large, the highest utilizer group that we had. So we actually called them our hub patients. And pun intended, we're trying to get our arms around them right now. So how we manage these hug patients, we have to go a step deeper than our breadth strategies. We have to go deeper with them. And so it requires more labor-intensive, resource-intensive focus. We looked at the various disease states, the discharge dispositions, where they were going to, why they were readmitting, and a lot of the actual analytics that we ran on it, surprisingly to me, and I think for most people, almost every single one of these 350 patients had access to a payer source. These were people that had a commercial insurer. Some of them were our team members. Some of them were Disney cast members. Some of them were our Medicare shared savings patients. We had a variety of these patients that had access to a payment source that payers, as fiduciaries of their care, should be helping us to navigate them. And so we were able to lean in on a lot of those organizations to help us with some of this, but also deploy these more specific targeted programs. So I'll just touch on the first column here, the high touch programs. We have two different programs that we run specifically. One, we already alluded to about the community paramedicine program. We're trying to deploy that as broadly as we can to all these patients. And of course, not all patients are going to accept it. So that's part of the reason that our target rate is not 100% there. And then we have a second program, that's our tuck-in program, which is effectively a tune-up program before the weekend. So we have our care managers call our patients that fall into this category every Wednesday. So it gives us 2 days of lead time before the weekend hits, and a lot of the resources, physician offices, et cetera, are maybe not as accessible. And that way we can help them with medication access, social service access, getting them in to see their PCP or their specialist before the weekend hits, and also let them know that they've got someone to call in the event of things going sideways over the weekend. So we deploy these resources, and a lot of times those calls are resource intensive because these people want to talk for 30 minutes, 40 minutes, an hour. We can't do that with every single patient, right? So this goes back to the using analytics to drive, process efficiencies and understanding where the greatest ROI is from a clinical delivery standpoint. So that's how we develop these depth strategies. And we obviously have other ones here on the slide as well. But I think the point I would emphasize is every one of these was data driven. We didn't, just set targets without baseline data. We didn't set things that we thought were unrealistic. We set targets that were specific and measurable and actionable.
And and that makes a lot of sense. I know we've worked a lot with you around thinking about dashboards and the use of dashboards to sort of see how you're doing. I have a question from the audience though for you. What has been the biggest challenge in executing this broad and deep set of strategies within your employee population? Like, how have you modified workflows, processes, reportings, incentives to address them? And what are you still working on that's a challenge? So you mentioned the operational owners, but maybe you can say a little bit about the journey.
Yeah, so I go back to a theme I mentioned earlier. It takes a village. When we look at our hospital contingency of all patients that are in-house at any point in time, only about 10% of our census is aligned to our employed primary care physicians. About 60 to 70% is aligned to community PCPs, and about 20% don't have an aligned PCP. So for the 10% that are aligned to ours and the 20% that don't have a PCP, we can readily, through our Epic EMR, schedule patients from the bedside with our bedside nurses or our unit secretaries and get a patient scheduled for a follow-up visit before they leave and make sure that's a hardwired process. Where the challenge comes in for us, and something we've actually been exploring with the Innovator team, is how we create a scheduling platform to make sure that every single patient can get in with the community practices as well, because there's fears of poaching, or urgent cares don't have the adequate resources to be kind of a transition clinic, or maybe we don't even have the capacity to take on those other 70,000+ discharges a year. How do we handle that? And so that's a big data piece for us. Right now, it's very manual because we're actually having to have staff call into practices on behalf of the patients, spending 30, 40, 50 minutes on a phone call, and then oftentimes the nearest appointment is 30+ days out. So that's not ideal. So how do we create kind of an Expedia or an open table type environment where we have instead of Sheratons and Hyatts and Hamptons and what have you, where you can schedule and directly book there. Instead, you've got eClinicalWorks and Greenways and Athenas that you can book into these community practices schedules. So that's one of the things that we're trying to work on right now. We know that, as far as our breadth strategies go, the biggest opportunity that we have is those follow-up visits. So we've been putting a lot of effort and energy into making sure that all of our patients are going to a follow-up appointment, whether it's with our employed or with our community practice affiliates.
Well, I know you put a lot of effort into managing how you're doing along the way, and dashboards seem to be an important piece of that. Tell us a little bit about the strategies you've taken across the board for dashboards, but then more importantly, the experience with readmissions and these broad and deep set of strategies you described.
Yeah, this is one of the more exciting things we got to work with Innovator on in the early goings of this. So when you think about readmissions and how you can track that data, if you're only using your incumbent domestic data within your own EMRs or perhaps even your billing systems, you're really not catching the full gamut of readmissions, right? When CMS is thinking about how you get dinged from a readmission standpoint, they don't care if a patient admits to your hospital, discharges, and goes to a competitor hospital. You're still accountable for that readmission. But we wouldn't in our own domestic data sets know about that. And so what we did to try to conquer that was we actually went to our state HIE partner, and they give us all the transactional data at all hospitals for any patients that leave our system. And we built with Innovator, what you see on the screen here, the first statewide readmission dashboard. So we actually have full real-time commerce. And I say real-time, it's literally within about 10 seconds of a patient registering at an ER or an inpatient location. that we know the patient has hit the door there, we can see any patient that's left our hospital facilities within the last 30 days and see if they landed at any other location. And this gives us a ton of line of sight to things that we wouldn't otherwise know. You know, why are patients readmitting? Is it proximity based? Is it certain days of the week? Is it condition based? And we're able to use this information to help us change our processes and perhaps even personalize our care for how we reach out to certain members and drive down readmission gaps that we maybe weren't even aware of without having this broader set of data.
So I have a question from the audience. You know, you talked a little bit about the owners for the different depth and breadth strategies. Now, the question is, how do you negotiate leverage over the owners of the KPIs, as they'll be in different parts of the health system and they may have different responsibilities in terms of their core job?
Yeah, it's a great question. So, you know, VPC, you know, Population Health Department has its own priorities and objectives, and we can't do it by ourselves. We have to work with our hospital partners. So we kind of evangelized this particular effort as something that needed to be a system-wide focus, and we got buy-in from the highest ranks of our organization. And our chief medical officer is actually the key champion at a system level for all things readmission reductions. So from that standpoint, we've got our chief quality officers at every single hospital. We have our hospital presidents. And then the real thing is that we built it into our bonus incentive package for all of our team members this year, right? So, you know, follow the money. When there's a corporate objective like that and it's tied to incentive, it really gets everyone rowing in the same direction. Absent having that, we can still make progress, but it certainly makes it a lot easier when you have everyone aligned from an incentive perspective as to why you're trying to accomplish this. And it has a ton of ramifications for other areas that people maybe are not even aware of, right? So if you reduce readmissions, it helps with throughput. You know, it helps the people in the ED from an operational standpoint. It helps the nurses on the floor. It helps clear space for more beds. It helps revenue cycle, right? A lot of the readmissions, not only are we getting dinged from a penalty perspective, but they're not positive contribution margin cases because we cost more to deliver care for some of these patients than Medicare actually pays. So those are all kind of considerations on how you can get buy-in from stakeholders that maybe don't have direct feedback or don't see direct value in what you're trying to do. But I would certainly say to the degree that you can create kind of a burning platform at the highest levels of your organization and that cascades down, that's been a huge win for us to get all hands on deck on this effort.
This is very impressive. I'd like to check in with our audience and see how this compares with their own care management strategies that they've been implementing. So why don't we take a quick poll and see if, for the audience, if your organization has a high-risk care management program and if it's a very sophisticated one, and how effective is it? In the meantime, though, I'd like to do two things while the audience is taking this poll. One is, you've mentioned the word platform several times. How do you think about that concept of platform, Brandon?
So yeah, when I'm alluding to platform, I'm talking about a unified data model that is pulling together a variety of different data sets, from clinical information that lives within your EMR to outside clinic information that's within our clinically integrated network, also including claims information, eligibility files, non-solicited lab data, and HIE data, among others, and being able to create that comprehensive 360 view of a patient. And I kind of described it earlier. Once you have that data layer, everything else is really applications and algorithms built on top of it and just how you visualize it. So being able to have that data helps inform a lot of the things that we're trying to do. And at that point in time, it's really just a matter of how you build out those reports and those dashboards to create high-risk care management programs, to create visualizations of tracking readmission reductions and what have you.
Yeah, I like the way you said higher risk care management programs, plural, because traditionally it's been very uniform. Paul, this is a very impressive set of programs that Brandon's walking through, isn't it?
It's very impressive and exciting. And I like to think of this as the move away from the master builder model that, you know, we had in healthcare, where the last industry that uses the brain as the data storage device. You know, and when you talk about a platform, that's the plan, right? I mean, you know, you need, if you're going to move to a team-based model of care, and you're going to build a skyscraper rather than a cathedral, you know, somebody on that team needs to know the tensile strength of steel, and somebody needs to understand, you know, load. And that's what's happening in healthcare, right? We're moving towards a team-based model of care. And you heard over and over again how they utilize teams to support the patient. Well, when that happens, where does that data go? Who's accountable for that? Who's going to manage that? Is really the whole concept of the medical home. But having a platform, having a place in the system where everybody on the team can sing from the same sheet of music and understand, the complexity of dealing with 100 diabetics. It's the same as building a skyscraper and understanding the complexity of that and knowing the tensile strength of steel. I mean, it's that simple, really.
Yeah, I think as Brandon said, it takes a village, and it takes a platform with data to help that village actually orchestrate their activities around such complexity. Well, let's check in with our audience and see if their care management programs are effective and what they think of the effectiveness there. Interesting. It seems to be all over the place. Paul, did you expect this?
I expected we would have more people in that moderately effective. I mean, I think we're we're making progress, and as I see around the country, more and more people moving towards this and gaining more experience.
Well, let's go in and talk about where this might be all heading. Sounds like there's a lot of work to do, and I think, Brandon, what you shared with the audience today really helped them think through what they might do to get their programs a little bit more effective. Let's move on and talk about the future of healthcare. So, Brandon, let me start with you. You talked a lot about engaging the community, thinking about food, shelter, transportation, all the stuff you've done around doing this statewide activity to find out when people are hitting other systems for their utilization. What do you think the future of healthcare looks with this concept of using platforms and data to really orchestrate these various players?
Yeah, I think we've really honestly just begun to scratch the surface of data integration. With the state HIE is certainly an interesting foray into how we begin to use outside data to do all things operational within our system. We had conversations even just yesterday about how we can work with county coroners' offices to get lists of folks who have passed away in the last several weeks or months, and being able to bump that up against our data to see 30-day mortality rates once they've left the hospital, because those reports aren't released from CMS for upwards of a year after they've happened. How do we become more timely and reactive to things when we can make changes, as opposed to waiting and driving, using the rear view mirror as the analogy. So I think there's a lot more data points that are going to come in. There's going to be an increasing focus, in my view, on social determinants of health. I keep bringing that topic up. But from our experience, the medicine side of things, by and large, we do a really good job with the medicine. A lot of the delivery of care is not what's going on in the walls of the office. It's why patients are seeking care to begin with, and maybe perhaps not seeking care, right? People having to decide between paying for their medicines or keeping their lights on. Those are things that we should be able to address from a pop health perspective that have downstream consequences that extend beyond just financial ramifications to us, right? So being able to pull all those different types of data sources in, credit scores, what have you, will just increasingly make our data set more rich and really evolve us to be very similar to kind of what an Amazon does with all of our data, in terms of our preferences and communication, omni-channel outreach, and what have you.
Well, both Paul and I have a public health oriented background in medicine. So the idea of going upstream to turn off the faucet instead of constantly mopping up the floor is not one that either of us are offended by, is it, Paul?
I had the privilege a few years ago of sitting in St. Johnsbury, Vermont, where they've taken 2 cents out of every sick care dollar and created what they call a blueprint for health. And of course, this I've seen in the work I've done in Denmark and overseas as well. But fundamentally, they bring all of the resources from the community once a month together to literally create a plan across the community for the patient. A young Anglican priest stood up and said, we'll never let one of our community members suffer an amputation because we don't have a plan around the patient. What is that plan? Well, if they need a coat, Goodwill Industries there. If they need some emotional support, their pastor's there. The newly diagnosed diabetic is introduced to the Diabetic Hiking Club introduce the nutritionist in the grocery store. Just really pulling the resources around them. I mean, we all know that, your diabetic that you send home with an insulin syringe, if they're living under a bridge, isn't going to do very well, right? But I think increasingly as payment moves towards a value proposition of a person in a bed is going to be a cost to you rather than a profit to you. We're going to focus on this, and it's exciting, interesting time to be alive.
Yeah, that raises a bunch of questions, and I've noticed questions started to flurry in. There's this issue on the screen of patient-generated data. That's sort of a new frontier of data. And often what we've learned is that health outcomes are different than clinical outcomes, right? What the doctor thinks may be the right thing. Lowering A1C is different than the patient's goals. And I think you alluded to this, Brandon. Two quick questions. And certainly we are looking at collecting that patient-generated data as part of it, and this is the piece we're implementing. It's the frontier. How do you think about these folks that are out of your purview, so to speak, meaning they're not employed by Orlando Health? There's the non-employed physicians, right, that are in the network, but then there's also these, like you mentioned, paramedics, not just home health agencies. So how do you think about engaging them? I mean, you're not able to compensate them. How do you think about aligning incentives? I know it's a new frontier area as well, but maybe you could give us your initial thoughts.
Yeah, so, with our community physicians that are partnered with us, and really anyone in our CIN, they have shared contractual goals with our different payer partners for the delivery of care, meeting different cost and quality targets. And if they do so, there's additional financial benefit to them for doing that through shared savings types of arrangements. And then in some cases, if they don't deliver on those, there's consequences in terms of financial penalty or perhaps even exclusion from the network. So there's certainly economic levers within the clinically integrated network frame as they're currently constructed. With regards to other partners that are maybe part of our ecosystem but not directly financially incentivized, as an example, our community paramedicine partners, we, to the degree possible, we try to strive to have skin in the game from all of our clinical partners, right? Whether that's post-acute network representatives rounding at skilled nursing facilities or community paramedicines going into patients' homes. There's still a financial component to them through, the referral channel and the fact that we're partnering with them and they're having access to the lives that we manage and potentially the health plans that we operate, our team member plan, our Disney plan, what have you. But trying to build in some financial withholds or financial benefits or capitation type models or other different alternative programs other than just fee for service helps to create greater alignment with those entities as well.
And so let's take paramedics as a great example. Issue goes on in the home, paramedics get in there. How do you think about connecting a group like that with what you're doing within the health system?
Yeah, so from a clinical data exchange standpoint, we leverage partnerships with them through a tech application that has API feeds into our system. So we're actually pulling in data at the time of care and being able to tether that to our other records. It's not perfect integration, and I don't know that unless everyone's on this tech system that it's going to speak perfectly, but to the degree that we can know that these events are occurring and get that to our centralized care coordination team, who's oftentimes the referral source for that service, we feel very confident that we're at least staying in the know of what's going on and having a good partnership with them, having grown it over the years. We feel very confident that the work that they're doing is producing the great outcomes, and that goes back to the process outcomes measurement that we're trying to develop with everybody we work with.
That you tied together some great concepts here. I'm going to bring a slide a little bit because you've talked about platforms. Obviously, in Evasor, we're a platform company. This is the way we, at a high level, think about things. And you've mentioned bringing in data from all these sources. Patient-generated data would be included here, social determinants of health data, and the more traditional clinical forms of data. And then unifying that in a patient record, a single unified patient record in as real time as you can. And then allowing through a platform that has API plugins where different other systems can plug in and have everybody work together as a team, whether it's applications we put together for the patient-centered medical home or for value-based care, population health. And I think lastly, if you brought in third parties, as you mentioned, that the tech-enabled piece that you're using to connect with paramedics and many, many others, plugging them into an API, just like your iPhone plugs in and you can accept different applications, and then being able to manage all of that in a private and secure way, but in an intelligent command center. Sounds like command centers have been dashboards have been a very important piece of this for you as you continue to experiment and get new learnings.
100%. That's exactly right. Creating one cohesive platform that our teams can use that plug and play from all these other solutions that deliver value is one, it reduces the world of crazy and makes it easier for our team members to operate within a single system, but two, it pulls upon the best resources that are out there in a cohesive way that we can deliver the best care for our patients.
Great, and I think, Paul, you can really applaud the work they're doing there to really think of working together as a team.
Oh, it's really exciting, and I think there's just some huge breakthroughs and just the ability to sort of move quickly. I mean, when COVID hit, they used those EMTs to do the lab tests and to do the EKGs so that they could do the screening for the surgery, right? It was just amazing. So thank you for all you do, Brandon. It's great. And to everybody in the audience, have a great weekend.
Yeah, Brandon, thank you very much. This was very enlightening for us all.
Thank you, guys.
Great, and thank you, Paul. And we will be in touch. We will send a copy of the slide deck to those members who attended today. And we'll also send a little bit about information about platforms and plugins and APIs and what we're doing here at Innovacer and some of our acknowledgments. Thank you both very much. This concludes the webinar, and thank you most of all to those who participated today. Have a great day.